Okay, good evening, everybody. Normal good evening to all. Today we'll have last week we had 4 clinical examinations, all the usual suspects: your cardiovascular system, respiratory system, uh, abdomen, and you had one CNS examination system. So today we'll see others. We have 4 other cases today. Uh, let's see how we should approach these cases. So I know you all know the timings. You'll have 4 minutes outside. Those 4 minutes have no role at all because these days they are not sticking the name of the station. So you may not be able to prepare, and it is better if you don't know what is the station, because your mind will be slightly calm. So you should be really calm to take up the clinical stations, because it can be the bouncer stations. Each and every different cases has different signs and symptoms, and different various stages of diseases. So you have to approach that very calm and um, I think most in a clinical station, the examiner may not be very particular about the diagnosis. So he gives mark how you treat the child, how you treat the parents. He gives mark on how you approach your examination, and then how do you elicit the signs and symptoms. Then how you piece all together. So each domain carries 2 marks. So he has to give marks in that way. Very rarely only examiners are very particular about the diagnosis. So I don't think you need to know the diagnosis. Most of the times they are very particular about the approach and how you treat the child. Last class stuff I told you. If the child has some concern, if the child says, I feel, you don't continue your examination. You just look at the examiner and see whether you can able to switch off the AC. So you address the concern of the child. Sometimes the mother may say, if there is an young infant, the mother may say, I need to change the diaper. You don't tell the mother, see, I have only 6 months, we will do it after that. No, it will grossly undermark you. So if the child wants to go to the toilet, you look at the examiner. The examiner will guide you whether he has to send the child or not. And in an adolescent girl or boy, you just see the examiner whether you want to do it or not. You want to see the Tanner staging or not. The examiner will decide whether you have to continue or not. If there is some difficult part of the examination, then you want to know whether you have to do or not. It's little distressing. Suppose, for example, in an abdomen examination, you have time and you want to look at the genitals. You can look at the examiner and say, I want to look at the genitals. Can I proceed, sir? He will say, no need. You just continue. So then you can skip that. But the examiner will give mark for that. So you have some concern for the child there. Okay. So let me start today. Rukshana, you are ready? Rukshana? Can we start with Rukshana?
Yes. Yes.
Okay. So let's start with Rukshana. Just time myself. When I say start, you're entering the room. Okay, you can start.
I entered the room, washed my hand, and introducing myself. Me, Dr. Roxana, one of child doctor here.
The examiner says, this is Wilson, 8-year-old with his mom, Catherine. The opening statement from the examiner is, examine his eyes.
Okay. Okay. Hello, Wilson. How are you? Me, Dr. Roxana.
I'm doing good, doctor.
Okay. So today I'm assigned to examine your eyes, doing some funny movement. Is it okay for you?
Yes, doctor, it is fine, doctor.
And I'm asking to mom, can I proceed?
Yes, yes, you can proceed, doctor.
Okay, okay. So I'm looking for dysmorphic face. I can see that okay, no, there's no dysmorphic face. I want to know about the dimension of Wilson.
He's well grown and uh, he is not dysmorphic and he has no any devices around him.
Okay, and then I'm looking for is no device, no glasses there. Okay,
He has no glasses on the table.
okay. So now is there any pain, any kind of distress?
No, he is not in any kind of distress.
Okay, so I will no, I will sit in front at the level of William. And William, which class do you read in? I want to making a repo, and then I'm doing the first of all the test for the visual acuity, near vision, and the far vision. So, is there any Snell's chart in this room?
There is no Snellen chart. There is a calendar across that wall.
Okay, so yeah, I will ask, can you close your one eye and read how much line up to the below?
He's closing his left eye and he's reading the numbers.
Okay, and what's about the right eye?
He's closing the right eye and he's telling that I'm not able to visualize the numbers.
Okay, no problem. And then for far vision, I will give him a book, and probably it will be if there is any colorful book at the same time near vision and for the color vision. Is it okay?
Yeah, there is no colorful book there.
Okay.
You can test with this dress or something like that.
Okay, so individual eye, I want to see that is there any color vision blindness such as the red, green, and yellow color. Can he
Uh,
recognize?
he is able to identify the colors. He is able to tell the colors.
Okay. Now I'm looking for the accommodation reflex. Will you please look at the calendar and then look at the nose? I'm looking for is there any accommodation problem or not?
See, his left eye is not moving properly.
Okay.
It is moving, but it is not as per the right eye. I think you have some internet problem, Dr. Chan. Others, can you hear me? Shrikant?
Yes, sir. Yes, sir.
Yes.
Yeah, I think she has some.
Now, is it okay?
Yeah, you please continue.
Okay, so now I will looking for the H-shape movement for the movement of the eye muscle. I will sit at the same level and I will close the eye opposite to his eye, and I will say that you will follow and not please moving your head, and then I will look for the H-shape movement for any ophthalmoplegia present or not.
There is, when you do the head shape movement, there is no any nystagmus. Anything else you want to ask for during the head shape movement?
Yes. During this movement, is if you say any double thing, please inform me, or any visual disturbance, please inform me.
No, he says there is no double thing.
William, you are doing a great and you are very cooperative. Okay, so then I will look for to complete examination, I want to do the fundoscopy. And yes, can I check
Ask
the
you to skip fundoscopy. Examiner ask you to skip fundoscopy.
okay? Then to complete my exam, and now I'm looking for the field of vision. And
Okay.
in field of vision, I will check the eye, separate eye, and I will tell him that when I will check in the temporal and the temporal region at the nasal side, up and
How do you check for the field of vision? Can you open your camera if possible, and can you tell us how do you check for the field of vision?
yes, I will check like this. I will close my eye and I will do this movement at 2, 8, 4, and 10 o'clock. And whenever you see this type of movement, please inform me. This is the field of vision for the right eye, nasal, and the temporal. And on the opposite eye, I will close the same eye. And whenever I will look for whenever I see the moving of my little this finger, will he able to see or not? This is how I will check the field of vision.
Can you tell me how do you position your hand? Okay. Okay. Anything else you want to, doctor, finish with?
I want to see that another picture you have shown me, that whenever movement, there is possibly any prosthetic eye is there. I'm confused because you shared another picture.
No, that I shared inadvertently.
Okay.
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 So, anything else you want to finish with?
To complete my examination, I want to do the formal vision assessment.
Okay.
And also for the test for squint.
Okay. Okay. You want to do a cover and uncover
Yes,
test.
yes.
Your time's up. Okay.
Okay.
Okay. So, anybody wants to take this case again? You take this child. Anybody is interested to do this? And then we'll give some feedback. Anybody wants to try? I'll give 5 minutes for them again.
Sir, I want to try.
Yeah, please. Your name?
Sir, my name is Solat.
Okay, you are from which place?
I'm from Dubai.
I'm from Dubai. Okay. Shall I start the timer?
Solat, S-O-U-L-A-T.
Yeah, okay. Shall I start the timer, doctor?
Yeah, please.
Okay, I'm starting the timer for you. You can start.
Okay. Firstly, I'll enter the room and I'll introduce myself.
Okay.
Hello, Wilson. I'm Dr. Solat Hafiz, one of the PEDS doctor here.
Hello,
And
doctor.
hello, mommy. How are you doing?
We are doing
So,
good.
yeah. So, Wilson, I just want to examine you if it's okay for you.
Yes, doctor.
So firstly, I'll just look at the child and observe his facies and his height and weight. Either he's like appropriate according to his age.
Okay.
And I will like to see any dysmorphic features there on the face.
No pictures.
And while talking with the child, I'll just see his intelligence, like how if his speech and his is according to his age or not.
Okay.
And he's replying to me, and he's conscious and oriented.
Okay.
Okay. Then, sir, as my command is examine his eyes, I'll just go in front of the child, and I could just ask. I'll just see if he's wearing any spectacles or not, or yeah, and if there is anything on the table, or
No.
I'll just
Baba,
and then sir, I'll just ask him if there is any asymmetry of the eyes.
Okay.
And when I I'll stand in front, I'll just see if the eyeballs are in the center or not.
Okay.
Check for the screen. All right. So then I'll start the examination. Firstly, I'll just, if there is, I'll check the visual acuity first. All right.
Sorry. Yeah. Go ahead.
Okay. So firstly, I'll check the visual acuity, and if you said there is a calendar on the back, so I'll just ask him to just close his one eye and check that. And if he could read the last line, that is in, or the words that are smaller, and then I'll repeat that with the other eye.
Okay.
So the way you
He's not able to visualize with his left eye, but he's able to visualize with the right eye, the numbers.
all right. Okay. And then I'll just with the left eye, if he's not able to visualize what is he able to see my hand? I'll just wave my hand in front and I'll see if he could see that.
He's able to see your hand on the right eye, not able to see on the left eye.
Not able to see on the left eye. All right.
Yeah.
Okay. Then I'll just do the direct and indirect light consensual reflex. I'll just put the eye on his left eye to see if he could just perceive the light with that eye, left eye from the side.
Left eye pupils are dilated, but the right eye pupils are not dilated.
Left eye pupil is dilated.
When you throw light on the right eye, the right eye pupils are dilated, but the left eye pupils are not dilated. And when you throw light on the left eye pupils are not dilated, and the right eye pupils are also not dilated.
Left eye. Sir, you are saying constricted or dilated?
Dilated. It's constricted.
Yeah. So like when you are putting in on the right eye, the eye people get constricted, but not of the left eye.
Yes.
Okay, but the left eye is not showing any response.
The left eye is not showing any response. Both
with
for
direct,
the direct
and indirect. Yeah.
Consensual.
Direct and consensual, both for that. Okay, sir. Yeah. Sir, then I'll just want to see. I'll just ask him to just close his eyes.
Okay.
And then squeeze his eyes. So
okay.
if he's able to close his eyes.
He is able to close his eyes, and you feel that the left eye is slightly harder.
Left eye. Is it able to completely close his left eye or not?
He is able to completely close his left eye. When you palpate the left eye, it is slightly harder than the right eye.
All right. So after that, I'll look for any. I'll just observe the orbital area for the eyeball, or I'll just see if anything there. I could palpate. I could find anything, any mass, or if there is any hardness.
No, when you palpate the left eye, you feel that the left eye is slightly harder.
Okay, that is the only
than the right eye.
All right. Okay, sir. Along with that, I would also like to see the conjunctiva of the child, both eyes.
Okay.
And I would like to see his lymph nodes of the preauricular, postauricular, occipital, and then this anterior cervical, posterior cervical chain.
No, the examiner says you need not go to the neck.
All right. Along with that, I would also like to check his BP, blood pressure.
The examiner says not needed.
All right, then I would just like to check his like heart rate, the vitals. If he's anemic, I'll check his conjunctiva. I have checked before, and sir, that only.
Your time, sir. How do you want to finish it?
Yes, sir. What are you saying? Sorry.
Your time, sir. How do you want to finish it?
Okay. Okay. So just generally, I just want to check his vitals, like the heart rate
Okay.
and the respiratory rate. I would just want to auscultate his lungs and want to check his liver.
Okay.
Sir, I summarize.
Yeah.
Okay. Good evening. I have just examined an 8-year-old boy, Wilson, who was oriented with time, place, and he with no dysmorphic features, and
Okay.
and he was well grown according to his height, his age. But I would like to place his weight and height on the. I would like to assess them on the growth charts as well. While doing his examination of the eye, my positive findings are that his left eye, visibly, there is no swelling or any discoloration. And when I checked for the vision of the child, the left eye, he is unable to even perceive the light, and he could not assess the hand movement. That means he's completely blind from the left eye. He's unable to see anything. And on during the direct and the consensual light reflex, his left eye is not perceiving anything. That means his optic and this oculomotor, both are their afferent and efferent parts are not working. I forgot to assess the movement of the eyes. Actually, sir, I just had like heard whatever the previously you have said, so that that he is able to move his eyeball in all directions, in the edge directions, and then on palpation of the eyeball, his left eye is harder than the right eye.
Okay. So what if at all he has an artificial eye on the left eye, what will be the causes?
Artificial eye. So
Yeah.
it could be a case of rhabdomyosarcoma of the left eye that
Most
has been operated.
most common.
From
Uh,
Most common.
Most common. Sir,
Most
the
common
name is not coming to my mind right now.
retinoblastoma.
Yeah, retinoblastoma. Sorry. Yeah.
Okay. Okay, let me give feedback for both of you from both of your point of. So you have to do the hand hygiene. I think I don't know whether Rakshana said hand hygiene or not. So you have to introduce Rapo. Everything is fine.
Okay.
And
Yeah.
I just want to know how his growth, growth. You can mention like that. And I just want to see any dysmorphic faces instead of not asking the examiner what is his dimensions. So some of the examiners don't like this word dimensions. So everybody has this mnemonic dimensions, then devices, whether he's dysmorphic and he's in distress. But I just want to know whether he's in distress, and I want to know whether he's dysmorphic. And I just want to know whether he's growing well or not. Like that, you can ask in a polite way.
Okay.
So that is fine. And both of you should start with inspection. So your eye examination should start with inspection. So you go in that order. You don't come in between how his conjunctiva looks like. So you see whether he has any head tilt, whether he has any ptosis, whether he has
Yeah.
any lag, proptosis. Do you see that there is a small difference in the eyes in inspection itself? So
So there is slight.
yeah. So there
It's
is
not that observed, but there is slight, like the eye is.
yeah. Your examination is eye. So if your
Yeah.
examination is CNS, then you can skip that. But your examination is eye. So I feel the left eye is slightly bigger than the right eye. So or if there is any congestion around the eyes or any periorbital edema, sometimes the your artificial eye may be new. So
Yeah.
there may be some periorbital edema. whether he has any obvious congenital cataract or any squint, any
Yeah.
cataract, maybe congenital or acquired cataract. He may have
Okay.
a trauma and he could have developed a cataract. So any squint. So all these points you can tell in a flash in inspection, and then you go to the visual acuity. Good that you both checked separately, and good that you both asked for the glasses. So you have to ask for the glasses before you check visual acuity. Sometimes what the children may do is they may keep the glasses in the pocket. So the examiner will specifically make the children keep the glasses in the pocket, and they may say, I'm not able to see. So most of the times there won't be any Snellen chart. So you can see across the wall and ask them to read some line, or ask them if there is a calendar, ask them to read some numbers, show them some numbers quickly. And then will you do the light reflex or will you do the color vision?
So,
I
both are part of examination.
part of examination. You bring the examination using the lights little down together, fundoscopy and light. So even sometimes the examiner will ask you not to throw light at the child. So if everybody throws light at the child, he may feel little awkward. So you go for the color vision and ask them.
Okay.
You check the color with the specs. If he has specs, you check what is the color. What is the color of my dress? Can you tell me? You show some primary colors to them, not some
Okay.
violet or some pink or something like that. You just show some primary colors, and then you go to the field of vision. How do you check for field of vision, Rukshana? Can you just tell me how in words how do you check for field of vision?
Yes, in case of this, we have to check differently, bilaterally, one by one. And
Yeah.
whenever I'm checking the suppose the right eye, then I will check this for my eye field also. And
Okay.
if
So you have to close the same eye.
yes, same eye, yes,
Okay.
same eye. And at the same level of the child, and
Yes.
then I will check for the temporal and the nasal field.
Okay, so basically one point is you have to be one meter at the distance from the child, and your hand should be in the middle, not by your side. If your hand is in the middle, then only you will see your hand. If you keep your hand by your side, the child will see your hand, but you may not be able to see your hand. Can you just try and see? The hand should be in the middle between yourself and the child. So you bring wiggle. So now I'm not able to see. Now I'm able to see. So you bring in all the four quadrants and see. Okay. So you have to wiggle, keep wiggling it. Can you understand? Is it? I just that's why I wanted you to open the
Yes,
camera and
thank
show me.
you.
So you bring the hand in the middle. So the examiner will be very particular to see whether you are doing it in the middle. Then only you will see and the child also will see. So that is one point. And then range of movement. Range of movement is easy. So you can ask for head shape, movement, and see. Tell the child if you find there is some kind of double vision, then you tell me if you have double vision. And you said with perfectly that you have to ask for diplopia. And then if the child has squint, so you do the cover and uncover test only if the child has squint. Since the child has no obvious squint, I will skip the cover and uncover test. If you have any doubt, then you pick up the torch and ask the examiner, can I shine the light on the child's eyes? If he says okay, then you please do it. So you show the torch from far off place and see whether the light is in the center. If the light is not in the center on both the eyes, then the child's alignment is not perfect. The child has some squint. Then you go near the child, show the torch on one side, see for the direct reflex, and keep your hand like this and see for the consensual reflex on the other side. And then you show the torch on the other side, see for the direct reflex and see for the consensus reflex on the other side. Somebody has put in the chat that I don't understand the findings. See, this child has an artificial eye on the left eye. Okay. So you show the torch on the right eye. So you see for the light reflex on the, you see whether the pupils are getting constricted. And then you see the consensual reflex of the left eye. The left eye is an artificial eye. The left eye will not have any constriction, pupillary constriction. So then you shine the torch on the left eye. When you shine the torch on the left eye, there will not be any direct reflex, and there will not be any consensual reflex also. So you do that. Okay. Then you ask the examiner whether I should check the fundus and see if there's a fundoscope. And then finally you palpate the eyes and you see. If you are in doubt, you palpate the eyes. And if some children are very smart and they can even pull the eye out and give it to you in the hand. So you have to go in this order. Okay. So please don't pull up the torch, show the light, and then go back, then ask for fundoscopy. So don't keep doing this. If you keep doing this, then the examiner will not be very happy. So the examiner may be very unhappy. So you have to do in that order. Okay.
Sir, as you said at the end, after fundoscopy, what we have to do?
So you at the end, you show the torch and see for any squint. If there is no obvious squint, then do the direct and the indirect light reflex using the torch. Then you ask and show the fundoscopy. Then you palpate the eyes. See, if you feel that it is an artificial eye, he has no vision on the left eye, then you palpate the eyes. So,
sir, one more thing, sir. Sir, as you said, initially we have to ask for the glasses, whether the child has kept in his pockets or whether he is wearing or is it on the table. Sir, do we need to do the visual acuity along with the spectacles and without spectacles, or only without the spectacles?
See, if the child is not wearing spectacles, he says, no, I don't have a spectacles, then you can do the visual acuity. Without then it there itself. If the child says, I am having the glass, then you have to do it with the glass. I think you don't need to do it without glass. Some authors say you need to do without glass, with glass, then your examination will be over there itself. You may take a lot of time there. So if the child has glass, you do your visual acuity with the glass.
Okay, sir. Thank you.
Examiner may ask you, how is it a myopia glass or a is the glass is for hypermetropia? Can you tell me, Dr. Sheikh, whether the glass is for myopia or hypermetropia?
Sir, if it is if the child is able to not able to see the calendar, then he is having short-sightedness.
So you have to look at the glass and tell.
Look, sir, if it is convex or concave, based on that we can tell.
So you see through the glass. Okay. Can anybody answer this?
Yes, we will ask for the paper, and then we will check the glass, and we will check whether after putting the glass, the word is become smaller or larger.
Very good. So if it becomes smaller, then it is a.
It is if it is smaller, then it is myopia.
Very good. So it's a smaller, then it's a myopia. Okay. So
thank you, sir.
Thank you. You have to do your hand hygiene, everything. You have to do your DDDD. Then you have to do all the inspection findings. Then you have to do a visual acuity with the glass, separate eyes. And if he's not able to read like this in this child, then you can show the hand movement and the finger counting. And even if it is not there, finally, when you are shining the light, you can ask him whether you are able to see the light, because light perception is the smallest amount of visual acuity. Then you do the color vision with the specs. You ask for the primary colors. Then you do the field of vision. Keep your hand in middle. Then you do the H test for the diplopia. If the child has squint, then you do the cover uncover test based on what type of squint it has. Then if the child finish it with their your torch and your fundoscopy, finally you palpate. Yeah.
So for checking for eye movements, We
Yeah.
need to check both the eyes simultaneously or
Yes, you have to check both the eyes together.
simultaneously, right?
Very good. Because for your field of vision, you check with individual eyes separately. For your head-shaped movements, you check both the eyes together. And your expected key in this station would have been whether you have identified absent vision on the left eye or not. Then you ask the permission to the examiner whether you can show light or fundoscopy. So these are the important points that the examiner is going to mark in this station. And finally, you tell them the diagnosis that it's an artificial eye. So I've shown these photos several times. So anyway, I'll show it again. Okay.
Sir, so like before checking the direct and consensual light reflex, we'll ask the examiner first if I can just check it with the torch.
Yes, you have to ask. You have to ask.
Okay.
Especially in the eye exam.
Sir, but if see when we're examining the child, of course, at that time we'll get to know it's an artificial eye, and it's difference in the picture, and then when we'll be seeing it, no. So, sir, then there is a need to do the fundoscopy and ask for it. Like in the end, there is a need.
Most of the time, you won't come till fundoscopy in eyes. You can tell I will finish it with fundoscopy. So most of the times, if you are too smart and too fast, if you have reached that level, you have to ask whether I can do. Okay, certain examination you have to ask. Okay, so how will you do the fundoscopy? If the examiner is going to give you the permission, go ahead and do the fundoscopy.
So first I will see red reflex basically from a distance for both the eyes, and then try to see the fundus from nearby.
Okay. Good. Most important thing is you switch off the light.
Sorry, couldn't get you, sir. Most important thing is
switch off the light. So you have the lights should be a little bit switched off. The room light should be dimmed.
Okay.
So if all these the examiner may not permit. So that's why you can tell the examiner, I need to dim the room a little bit. So he said, okay, please proceed with the other examinations. Okay. So the discussion is over. If there is
Sir,
any
I have a
doubts,
request.
I think.
Sir, I have a request. If you could just summarize this case the way you explained it, just summarize it in the end, like we do for the exam. That would be great.
Okay, you want. Okay, so today I examined 8-year-old boy Wilson on examination. Inspection, his left eye appeared to be slightly bigger than the right eye, and on checking his visual acuity with the glasses, his left eye has no any perception of vision, even to hand movement, and his right eye has a direct reflex. His left eye had no direct reflex or consensual reflex from the right eye. And will he be able to move the eye? Can anybody say?
He won't be able to move it.
How many? Anybody says, can he able to move? See, sometimes this can be a permanent attachment. So sometimes it can be a permanent, and the muscles can be attached to the artificial eye. So in that case, he may be able to move the eye. If it is a temporary, it is attached outside and is able to remove it, he may not be able to move the eye. So that point you may need to tell. So his visual acuity is like that. He had color vision on the right eye. He is not able to perceive the color vision on the left eye, though I didn't check individually. And then I checked his field of vision. His field of vision on the right eye is adequate, and since he is not able to have any vision on the left eye, the field of vision could not be tested on the left eye. And his range of movements appeared to be normal on the right eye, and the range of movements, there is no any range of movements on the left eye. Since there is a squint and I didn't proceed with the cover uncover test, and since I want to finish it with the fundoscopy examination, and on examination, his left eye is slightly harder than the right eye. So I would like to comment that it's a artificial eye, probably due to surgery, post-surgery. Probably most common cause is retinoblastoma. So I think we are already late. We'll go to the next case. Who's going to take this case? Srikanth?
Sir.
Yeah. Your time starts now.
Oh, okay, sir. I will enter into the room. I will do my hand washing. Hi, good morning. This is Dr. Srikanth, one of the child specialists today. I would like to examine your joints. Is it okay?
Yes, doctor. Please, doctor.
Okay. Let me have a look at from the bed end. How the child is looking? Is he well or sick?
He's well nourished and he's taller than his age.
Is there any attached devices?
No, there is no any attached devices.
Okay. Is the child is in distress?
No, he's not in distress.
Any dysmorphic features?
No dysmorphic features. His face is slightly long and thin.
Okay. I want to ask few questions. Is it okay?
Yes.
Chandru. So, do you have any pain in your joints?
No pain in the joints.
Do you have any difficulty in dressing or undressing?
No difficulties in dressing or undressing.
Okay. Does the child is having any difficulty in going up and down stairs?
No, no. Others can put your comment in the chat box. Continue, sir.
Okay. I would like to ask the child to walk.
Okay. He's able to walk well.
Okay. Is there any abnormality in the gait?
He's slightly walking unsteady. His feet are nicely planted on the floor.
Okay. Okay.
But he has generalized laxity.
Okay. So I would like to ask him to bend, and I will ask him to touch the floor.
Yeah,
Is he
he's able to bend and touch the floor. How do you want to bend and touch the floor?
So I will ask the child to bend and with straight legs.
Touch the floor. How you want him to touch the floor?
With the hands flat.
Palms. Okay.
Yes, sir. With the hands palms.
Yeah. So he's touching the floor like this.
Okay. I would like to check his arms. I will make him sit, and I would like to examine his arms. I will ask the child to encircle the wrist of the opposite hand. Is he able to do? Is there ring sign is there?
You're talking about the wrist sign?
Yes, sir.
Yeah. Your wrist sign is positive.
I will ask the child to adduct the thumb across the arm, across the hand. Is he able to do that?
You want to do like this?
No. No. I'm asking like this, sir. Across the hand, adduction. Thumb sign.
He's like this. Yeah. Okay.
Yes, sir.
He's able to do. It's crossing.
In the palm border, lateral border, medial border, sir.
Yeah, it is crossing.
Okay, I will ask the child to touch the forearm with the thumb. Is he able to do that?
Yeah, he's opposing his thumb to the arm.
Oh, bilaterally, both the hands. I want to check.
Exactly. Very good.
Okay. I will check the little finger of the both hands. Extension or bending of the little finger. towards
Very good. He is able to do on both the hands.
Okay, I would like to check his extension of the upper limbs, both the upper limbs. How is the extension? I want to check the angle. See the angle.
Elbow.
Yes, yes, sir.
Okay. He is able to do it. He is able to hyperextend the elbow. At least 10 degree, 10 to 15 degree.
Okay. At the same time, I'm asking, I want to check his lower limb extension also.
Okay. He is able to extend the knees well. Hyperextend.
Okay.
How do you want to check the lower limbs?
So I will ask the child to extend the knee joint.
By
So
making stand or sit on the couch.
Standing, sir, standing. So by that I can see the curvature.
Okay.
Is there any more angle?
Yeah, he is able to extend the knees more than 10 to 15 degree. Both sides.
Okay. Yes, that's it, sir. I want to, in order to complete my examination, I will take his vitals. I'd like to check his skin. I would like to.
He missed, you can type it in the chat box. You continue. Anything else he missed, others can type it in the chat box. Yes, please. You have 60 minutes, 60 seconds more.
I want to check his back. I will ask the child to remove or raise their t-shirt. I will like to check his spine.
Okay. Good.
Whether is there any deformity in the spine, I would like to check, and I would like to examine his oral cavity also for the high arched palate.
Okay.
And I would like to check his nails also. And in order to complete my examination, I would like to document his vitals, and I would like to plot the centiles, growth centiles. I would like to examine his cardiovascular system, and I examine fundoscopy. I would like to do fundoscopy.
No fundoscopy. Somebody has given you a clue in the chat box. Okay, your times are very, very well taken, actually. Very well taken. I should appreciate you. I didn't go with the usual command. I didn't tell you that here is a 7-year-old approach or with a tall stature. How do you approach him? So that will be the usual command. But I went for the other command. So both are same, except that if you are going to examine the tall stature, then you go with all these. Okay. And if you feel if the child has joint laxity, then you do the Beaton's staging. Okay. Okay. If the examiner is directly going to give you that examine this child who is with hypermobile joints, then you go with the Beaton in between. So you did very well there. So you didn't do Beaton separately. So that's one very good effort. I think you're being trained very well. Some of the points that I want to tell is, see, most of the systems you always start with the hand. That is one point. And the other point, you may even skip the 3 questions on MSK questions.
Okay, sir.
So you don't, the examiner is not going to tell you that examine is joint. He has given you a specific command that it is going to be a hypermobile joint. So I think you can skip that MSK 3 questions. You feel he is in pain or his joint is swollen, then you can say I want to ask the 3 questions. If you feel he's not in pain and it's not going to be a MSK, then I think you can skip the 3 questions. Even if you're going to ask the 3 questions, it is okay. Only place where you can ask history, the entire clinical examination station, is these 3 questions. So that is okay. Then you can ask about his general body status. You can see, I told you his face is long. So does he look like is he having any special habitus? How is his posture? Is he stooped, or is he sitting straight? Then you start with the hands. I always prefer you start with the hands. You go to the arms. Anything else you want to check in the arms?
Arms.
You have to. Last class I told you you have to move like Muhammad Ali, like a butterfly in the ring. So you should start with your hands and then check his arms, go to his head and neck, come to the chest, then go to the back, look at his spine, and then come to the legs and finish with the feet and the gait. So that will be a better plot. That's how it's there in your mark beating. So that is a better ploy actually, because you ask him to get down, then you make him sit in the bed. So that those small things the examiner may not like, but it's okay. So anything else you want to check in now? Murtaza, Dr. Murtaza?
Pulse, sir.
Yeah. So what?
Collapsing of the pulse.
Collapsing. So you have to look at the collapsing of the pulse. And as Murtaza said in the chat box, you have to look at the eyes, but you may not see anything. Even if there is a dislocation, dislocation has to be checked in slit lamp. So you can tell, you can verbalize that I'm looking at the eyes for any obvious dislocation of the lens, but I know it is better to see through the slit lamp, then come to the mouth, see for the high arched palate, look there is anything in the neck mask. Then you will always have a chest wall deformity in these children. So you have to look at the chest. Can I look at the chest? Then you if possible, you can put your step also and see for the mitral valve prolapse, or you have aortic regurgitation. So these things you can do. And see for the spine. When he bends down, you assess for the scoliosis. Then you look at his legs and you have to extend his knees. Ask him to extend his knees. Preferably, you can do it in a sitting position. Then look at his feet. Look for the pes planus. See whether he has no arch in the feet. And then you ask him to walk and show whether his gait is okay. And you finally finish with your height and weight centiles. And if there is time, what will you do? Anybody? If there is time. Skin examination, you can finish the skin examination when you're doing the arms. You can see for the scars and the bruises, and you can do the skin examination just to see if it is very lax. But if you have time, anybody?
Family members.
BP, sir.
BP, okay, there is no BP. There is only one instep there.
Neurocutaneous markers are on the chest.
Look at the
neurocutaneous markers are on the chest. Whether it's cafe or spots.
So there is one instep left in the table.
Okay.
Arm span, sir.
Arm span and height difference.
How do you check for the arm span in the exam?
Sir, both the hands extended widely on the sides, and from middle finger to the middle finger, sir.
It will be very difficult. No? You have how do you put
manubrium sterni to one column, finger to manubrium sterni, then manubrium sterni to or else the medial end of the clavicle, sir.
Normally, we move these children to one corner of the wall so that
exactly.
And very then see the other one.
Very good. So that's how you cracked it. You move him to one corner of the wall, see whether his hand is hitting on one corner, and then you see what is the where his hand, the other hand is, and then you ask him to come out and you can mark immediately. So you can do it in a faster way. You practice this and see in your hospital for normal children. Move them to the end of the wall. So put his hand on one side of the wall and then mark the other hand in a small pencil, and then you can measure. It will take a minimum of 20 seconds. But if you have to measure from one end, then it may take a little time. But if awkward or if there is an inch tape, then you better do a arm span. See for the arm span. And sometimes the examiner might have kept the your height chart or something like that. So you have to compare it and tell him. It's a very easy station. So the most important takeaway point here is, as Srikanth did, you have to do your bring your beaten inside, and you have to not separately pull your beaten. I'm going to finish with the beaten. So you ask him to bend again. So incorporate your beaten into the examination. So that's a very good point. Okay. I will move to the next case. Who is going to take the next case? Mutasa, you are willing to take the next case?
Okay, sir.
Okay. So, that's not the next case. Okay. Your time starts now. You enter the room, greet the examiner. The examiner's opening statement is, examine this 14-year-old boy Henry's abdomen.
So I'll enter into the room. Good morning, sir. Good morning, Henry.
Good morning, sir.
So this is Dr. Murtaza, one of the pediatric doctors here. So I'll be examining to you, Henry, today.
Yes, sir.
Is that fine? If you feel any pain during the examination, just let me know.
Sure, doctor. Thank you.
So any dysmorphic faces for the child, I'll see a general examination of the child. Any dysmorphism which is present?
There is no obvious dysmorphism.
Any devices nearby?
There is no devices nearby.
How are his height and weight like? How is his growth like?
He's short for his age.
Okay. Hope that he is not having any distress per se. He is not sick.
He's not sick.
So, Henry, I'll be just seeing your, can I just see your hands? Like, just like, can you do this hands for me? So I can see that his palm is there. His fingers look a bit longer to me, and it looks dry. And he has some bruises in the around the elbow. Okay, with a obvious swelling of in the elbow region, which is like
Okay.
elongated thing, and there is a scar also below it, which is there.
Okay. Do you want anything else in the hand?
Am I able to palpate the pulses both the sides and
You are able to palpate the pulses both the sides, but on the side where this kind of swelling is there, you are able to feel the pulses more harsh. It's little bounding, and you can feel some funny type of pulse.
Okay. So if BP machine is there, I'd like to see the BP also and see for the like if it is like there is a wide pulse pressure on this particular limb. So then I will see then I will see for any clubbing, like if would you Henry do this for me like this.
There is some clubbing.
Okay. So
and this is pallor.
okay. Pallor is present with some amount of clubbing. I'd like to see the any axillary lymph node is there. And along with that, I'll check for the axillary hair if it is there and grade of hair simultaneously.
No, no.
Signs of puberty. No axillary hair is also there.
Okay.
Okay. No lymph nodes. So I'll just go to the eye examination. Can you just do this for me? See up and down like this to see for any icterus or pallor if it is present. Some pallor is present.
Yeah, no jaundice, some pallor.
Okay. Any other obvious signs like exophthalmos and all? Eyes are fine.
Eyes are fine.
Okay. I'll just, Henry, just open your mouth for me and show me your mouth and protrude your tongue. How is the oral hygiene and how is the dentition like?
Oral hygiene is poor. He has numerous caries.
Okay. So I hope you are brushing regularly, Henry, 2 times a day. Take care of this. You should brush for it. I'll just see your neck now. Any lymph node if it is there or any swellings in the neck?
No, no lymph nodes, no portacare.
So Henry, can you just lie down for me and I'll just see your tummy and feel for it. Is it fine for you, Henry?
Yes, doctor, please.
So I'll inspect for like the movement of the abdomen. Is it moving? How is the abdominal movement? Is it symmetrically moving? And any scars, sinuses, pigmentation, if they are obviously present on the abdomen?
Shape is normal. Symmetry is okay. Position of umbilicus is in the midline. Then it is not averted. You have a scar here on the right side. There is no dilated veins. Obviously, there are some stretch marks, some striae.
Okay. So I can see a scar which is like on the right iliac fossa, I think. Okay. Right hypochondrium, if it is. Okay. Then I'll just see for, I'll just touch your abdomen. If you feel any pain, then let me know, Henry. So I'll just do a superficial palpation and take the temperature. Any pain if he is having?
No tone, no guarding, no rigidity, no tenderness.
Okay, that's great. I'll just palpate a bit deep for you, Henry. I'll just start palpating the liver in the mid-clavicular line and start moving up. Am I able to palpate the liver in the subcostal area?
Yeah, you are able to palpate the liver.
How much below the left mid-clavicular line?
2 centimeters.
How is the consistency of the liver?
Soft.
It is soft. How is the surface of the liver? Is it nodulated or is it like non-nodulated?
Smooth.
Okay, it is
Smooth.
smooth. The surface is smooth. And then I will go up to check for the spleen. I'll start from the right iliac fossa, start moving up to the moving up. Am I able to palpate the spleen?
No speed.
Okay. Then I will try to
Your
just.
time. The
Okay.
time's up. You can finish in 30 seconds.
So I will just okay. So I'll just palpate for the upper border of the liver and see if it is what is the liver span, because my liver is 2 centimeters below it. And I will just auscultate for any brew which is present over the liver, if it is there. So in order to complete my examination, I would like to plot in, I will do a complete examination of the child in a proper fashion, plot him on age appropriate charts in it. And I would also like to do the supraclavicular lymph node palpation, which I have not done, to see if any lymph node is palpable in that case.
Okay. Anything else? If you have more time, what else you'll do?
So I will see for I'll like to see for other systemic examination, like respiratory system examination.
Okay.
To see for it. Okay.
No, you have to see if there is some fluid. No, obviously there is no fluid.
Right.
But you have to see if there is any fluid. Then you auscultate over the flanks and see. There's a scar also.
I didn't check for any ascites, right? I forgot.
Yeah. And you'll finish with the external genitalia, anus, and inguinal region,
To
and
see
your
for any hernias and all. Right.
edema. You have to see for the edema, pedal edema.
Okay, sir. Right.
So what do you think this scar is?
This is
You,
in
in
the
this 3 minutes, this 3 minutes is going to be your, like your examination end of 3 minutes in the exam. So we'll finish that in 3 minutes. So the examiner is asking you, what do you think is this scar?
as this scar is in the right hypochondrium, I will think that it is due to the some hepatic surgery has been done for him.
So it is in the right hypochondrium, or it is little bit
Below.
lower below.
Okay. If it is in the it is in the right inguinal fossa, it can be due to a appendicectomy scar also, but the scar seems to be quite big for that.
Yeah. So it is actually extending.
Sorry, I didn't get you, sir.
What is the, it is just extending to the back. What do you think is the scar then?
So then it can be a renal scar, like nephrectomy scar can be there in that case. And I was getting
Yeah.
a AV fistula also in the elbow. So
Yes.
so that can be due to the hemodialysis which has been done, maybe hemodialysis related.
So you should connect pallor, you should connect AV fistula, and you should connect the nephrectomy scar.
Right, sir.
Okay. So do you think this is a renal transplant scar?
Renal transplant scars. It can be a renal transplant scar. I'm not very sure, but.
Okay. So what you don't have if it is a renal transplant scar here?
Sorry, I didn't get your question clearly, sir.
If it is why it is not a renal transplant scar? Anything is not fitting here to tell that it is a renal transplant scar.
I'm not very sure of the answer.
See, if it is a renal, where is the renal transplant scar usually? What is the incision? Anybody?
Iliac fossa.
It is down. It is in the iliac fossa. You call that as Gibson's incision. So
Inverted J shape, sir.
yeah. So if it is going to be a Gibson's incision, or if it is going to be in the iliac fossa, you should be palpating the transplanted kidney. Okay.
Okay.
So you don't get anything in the palpation. Okay. So somebody has said non-palatable kidney suggestive of transplanted kidney. Good. And the kidney will not be in its usual place. It is in the iliac fossa. So
Lower down, right?
the mass, there should be a mass in the iliac fossa. Very good. So that's how. So what are all the possible ways that you can get a kidney case, Dr. Murtaza, in your exam?
So the kidney case can be in the form of like short stretcher with CKD can be there.
Yes, okay, one case. That means a child with chronic renal failure. That's all.
Chronic renal failure, right?
With pallor, you may have a AV fistula, or you may not be having a AV fistula.
AV fistula.
Or
Right.
you may have a portacath, or you may not be having a portacath. In that case, okay, then. Or you having some PD catheter also. Sometimes you may have a PD catheter in place, or some centers. Okay, then what else?
Then we can have cases of like enlarged kidneys, like they can be polycystic kidney disease, AD type or recessive type.
So you may get a child with a renal mass,
Renal
and
mass,
no scar, and no scar. You may not be having any scar at all. That's another possible case. Then this third case, loin scar and no transplant.
Okay.
It is a child with nephrectomy.
Post-nephrectomy, right?
Yeah,
Okay.
so this is a child with post-nephrectomy. Okay, so any other possible case, common case? common
Like
case.
pyelonephritis have occurred, which has led to like or hydronephrosis leading to
No, they may not keep surgical cases. You may get a nephrotic syndrome.
okay.
You may get a nephrotic syndrome where the child may be on steroid, so you may get a nephrotic syndrome. You may be asked to examine his abdomen. So you may have a Cushingoid phasis. So you may give the DDS. You should give the DDS a possible nephrotic syndrome. Child may be on nephrotic syndrome, and your child with a renal transplant. So you may get renal transplant with a palpable kidney in the iliac fossa. You may get a nephrectomy case. You may get a renal mass with no scar. You may get a nephrotic, or you may get a CKD with your AV fistula. So you may get all these possible 5 cases, and most of the times it will be examined the abdomen. Okay. So they may check whether you are doing the ballotability test to look at the kidneys. So all these points they may check. So good that you have picked up that it is a catheter. So that is good. Anything else? Anybody? Anything else he has missed? Anybody wants to add something?
Sir, in this case, do we need to do renal examination as well, right?
Yeah, you have to. He didn't have the time. He
Yeah,
was.
I got it, sir. But it was important, right, sir? Sir, in
Yeah, it is
abdominal
important.
case, do we need to do, suppose even if we get to know that this is renal case or liver case or spleen case, still we need to do examination of the other abdominal organs, or we need to keep it short?
See, if it is a very straightforward case, you've seen the scar, then you may not do the liver scan. You can tell the examiner, you can verbalize. He spent a little bit more time on the liver, whether it is soft or surface. So you just check whether the liver is not enlarged significantly. Then you move to the spleen fast. And as you said, you come back to the kidney and see whether the kidneys are palpable. Just do whether ballotability on both the sides and see on the iliac fossa whether you are creating the kidney mass there. So
Sir, whether we can
allot the
start with the
time.
Sir, whether we can start with the kidney and then go for the liver or spleen in case of renal cases?
How do you go about in the deep palpation in abdomen? What is Hutchinson saying?
Yeah, we start with the liver, sir. Yeah, that is there.
No, Hutchinson is saying that you
Go
start from
into
the
right
left
iliac fossa.
No,
Right
Hutchinson,
iliac fossa, go around the abdomen, then come towards the suprapubic, then towards the umbilicus, then back.
no, if possible, you take the Hutchinson and see. He says that you start with the left iliac fossa and come like this. So that's
Anti-clock.
what he is telling. He is telling anti-clockwise.
Anti-clockwise.
You can do either one way or the other way, but you don't see liver and then see the kidney on the other side. Then you don't see the spleen and then come to the kidney on the other side. That point only the examiner may not like. So if it is a clockwise or anti-clockwise, then it is not. Then it is okay. But he spent a little bit more time in the neck. So by practicing, it will be faster for you. You can do it a little bit faster. I think it is not a problem. You will definitely finish with the examination. Okay. So you understood though. So these are the possible 5 nephrology cases you can be kept. So you have to be ready, and the command will be still abdomen. So you have to be thorough with the scar. So see, most of the things you can practice online, development, your history, then your communication, all these things you can practice online because all these things are a dummy case. Your video is you can practice on your own, you can watch, but your examination cases alone, you have to practice in the hospital. So keep practicing in the hospital, pick up some normal child for the flow, and then once in a while, some 15 days, once you go to a regional center, We spent the entire day there. Once we went, when I was practicing, then I went to a center and I was seeing a leukemia child. Uh, he- so I asked him, do you have any other problems? He said, I'm having visual problems. Then he said, I don't have a vision on one eye because of some drug error or something like that. And then I did eye examination for him, and he said I'm limping. So I asked him to walk. I did the gait examination. So one more child who had a medulloblastoma operated. He has full cerebellar signs, and he had a tracheostomy. You can practice for a respiratory case. And then your cases will throw like anything. You can practice bit by bit if you go to a regional center. So you have to practice with the case. It is very, very difficult to do online practice in your MRCPCH exam. So you pick up some regional center, go for a day or two before your exams. Then you will get that flow, where that flow, and keep practicing. If you don't have a child, you can ask your normal children in the ward to do help you. And even if you are married and if you have your own kid, you can make them do MSK daily. It is good for you and them to do some practice, some exercise. So practice, practice, practice is the key in MRCPCH exam. So, Rohin, you want to take the last case? Rohin is there?
Yes, sir.
Okay, okay. So we'll end up with a small, fast, and easier case today. So, Rohin, you will be examining a 12-year-old Sophie who with her mother. You will be examining her neck.
Okay,
Your
sir.
time starts now.
Sir, I'll enter the room. I'll wash my hands. I'll greet Sophie. Sophie, how are you?
I'm doing good, doctor.
Okay. Sophie, is it okay that I examine your neck?
Yes, doctor.
Sir, I'll look at the surroundings for any devices. Are there any devices?
There is no devices. You have a small tumbler of water.
Okay. I would like to take her height and weight and plot on the growth centiles later on. Are there any dysmorphic features?
No dysmorphic features.
I would like to know whether Sophie is in any distress.
She's not in distress.
Okay. Sophie, okay. Sir, from the front, I'll be inspecting the neck. I can see swelling in front of the neck. There are no scars. And then I will ask Sophie to drink the glass of water. Is the swelling moving while she is swallowing the water?
Yeah, swelling is moving.
After that, I'll ask
It moves
Sophie
up
to.
and down slowly.
Okay. I'll ask Sophie to protrude her tongue out. Is the swelling moving while she's protruding the tongue out?
Yeah, it is moving.
It is moving. Okay. Then
Oh,
I will
you said
go.
no. You said
Sir,
it is while protruding. You said while protruding, not while protruding. It is not moving.
Okay, sir.
Okay.
After that, I will go behind Sophie and I'll palpate from back. I'll palpate the mass. How's the consistency, sir?
It is soft. There is no nodules. It is a diffuse.
Okay. Is there any tenderness?
No tenderness. It's enlarged on both the side. It extends on both the side of the neck.
Okay. Is there any warmth?
Yeah, there is not much of warmth. There is no signs of any inflammation.
Okay.
I would like to measure the swelling also on the length and breadth of the swelling. Then I would like to palpate the neck for any lymph nodes. Are there any lymph nodes?
No lymph nodes.
After that, I would like to do a percussion over the sternum, upper part of the sternum, to look for any retrosternal extension of the swelling.
How do you percuss?
So I'll percuss directly over the sternum, sir.
Okay.
So, sir, is it resonant or is it dull?
No, it is normal.
After that, I would like to do auscultation over the left and right side of the swelling. Is there any bruit?
There is no any bruit.
After that, I'll ask Sophie to show her palms. Is there any warmth? How's the temperature, sir, over the palm, dorsum of the hand?
You don't feel it is very sweaty or it is very too warm.
Okay. I would like to take her pulse for 10 seconds. How's the pulse, sir?
Pulse rate and rhythm is normal.
Normal. Okay. Sir, I would like to plot her BP later on. I would like to check her eyes. From above, I'll be looking for exophthalmos, whether the eyes is protruding out. I would be looking from above. Is the eyes protruding out, sir?
There is no proptosis. There is no lid edema or lid retraction.
Okay. I would like to see the eyes for any congestion, any conjunctival congestion, any lid, no lid edema.
There is no conjunctival injection.
Okay, sir. I would like to check. I would ask Sophie to squat and then get up. Is she able to squat and get up, sir?
Yeah, she's able to squat and get up. You have 30 seconds more.
I would like to check the knee reflex also, sir. How's the reflex?
Knee reflex is normal.
No, okay. Okay, sir. I would like to look at the lower limb for any edema or any swelling.
There is no
sir.
edema. No edema.
Okay, sir. Sir, in order to finish the examination, I would like to check her BP. I would like to do Tanner staging.
Okay.
I would like to yes, sir. That's it. And
Okay,
I would
good. No, you have done very nicely. That's very good. Mutta sir, can you tell me, do you want to make any changes here?
He has almost covered every part, what I think. Just like
Okay.
flow chart centile should be plotted.
Okay. So the flow. Anyone any change for the flow? He started with the neck.
Hand, it should be start from hands.
Okay.
Tremors and all should have been started, sir.
Right.
Okay, so there are two ways actually. You can start from the hand, then you go to the eyes, and then come to the neck. So it all depends on the opening statement. If the examiner say examine her neck, you can start from the neck. If the examiner says, because he doesn't know that it is a thyroid mass or any other swelling, it is a lymph node or something like that. So in that way, it is good. But if it is an obvious thyroid case, or if the examiner say examine her thyroid status, then you can start with the hand, because your thyroid status, your hands will tell more things about your thyroid status initially itself, whether it is cold or whether it is warm, how is the pulses. So you can start like that. You see for the tremors, and then you can go to the BP, and you can see for the eyes. You can watch the eyes from the behind or from the side. So that is one point. So it all depends on the opening statement. If the examiner says examine her neck, then you can start with the neck also. So that is fine. And you can ask her to say what is, whenever she's talking, you can check her hoarseness of voice. So that is one point he has missed. Any other devices you want to check, Rohin, which can be
Drugs.
kept?
Hearing aids.
Yeah, good. Hearing aids. What for hearing
Pen
aids?
rate. Pen rate.
Pen read, yes.
Pen read syndrome.
Pen read. Excellent. So you can have some hearing aids for the pen read syndrome. And dentition, hoarseness of the voice, you can check for the tongue, thyroglossal cyst. And then you have to inspect by making a drink water, and then you can palpate by making her drink water also. So you can make her drink water twice and see. And you did a very good direct percussion on the chest. So that is one most important direct percussion to look for retrosternal extension. And finally, how do you want to tell the diagnosis, Rohit? The examiner is asking you, what do you think is the diagnosis now?
Diagnosis is I had the opportunity to examine 12-year-old Sophie with swelling over the neck, most probably a thyroid swelling. She has no features of any hypo or hyperthyroidism. And no eye signs, and no lymph nodes.
Okay. So what do you
She's-
think is the diagnosis?
She has got a goiter, sir.
So first and foremost thing is it is a goiter. So it is not
Goiter.
a lymph node swelling, or it is not a cystic hygroma, or it is not a thyroglossal cyst, or it is not a sternomastoid tumor, or it is not some branchial cyst. So you have to convince that it is a goiter, because it is in the midline. It moves with the drink water. It moves up and down, and it is not a moving when you protrude the tongue. It is not a node because it is not in the sides. So all these points you tell there is no sinuses or there is no scar, and then you tell the thyroid status. So what are the causes for goiter?
Cause of goiter are iodine deficiency, Hashimoto's thyroiditis.
Okay.
Uh,
The most common goiter is
Iodine deficiency.
iodine deficiency. Okay.
Autoimmune thyroiditis.
Autoimmune thyroiditis. More than that, what is simple goiter?
Okay, which thyroid function is normal.
Thyroid function is normal. That means it's a pubertal goiter. You can have a
Right.
pubertal goiter. She's 12-year-old. So you can have an autoimmune thyroiditis. You can have Graves' disease on drugs, but you don't have an eye sign here. You can have a pubertal goiter. You can have iodine deficiency, pubertal, or you call it as a simple goiter. And it can be a diffuse nodular goiter also, but there is no nodules. So you tell the examiner that the points I will think of. So you have to these are the place where they will give marks. Okay, so good. You had a very good discussion. Anything else you want to know? Anybody?
Sir, do we need to do this swallowing test in this girl
Yeah,
to confirm whether it is a swelling or not?
yeah, they may keep water, or you can ask her, can you swallow your saliva like that? You may show and do. See, your 95% of MRCPCH exam is a little bit of acting. So you have to step up your level of acting a little bit. So you have to show that you can get it from that child. You have to show that. So if there is no water, you can show. I'm swallowing. Can you able to swallow it for me and show me like that? So
So
when she's swallowing,
sir, please
when
continue.
she's
Sorry.
swallowing, you have to palpate and then you have to insert.
Okay, so if during swallowing it is moving, it is a thyroid swelling. If it is not moving, it can be other differentials. Then the second
Yes.
goes that we have to make him protrude the tongue. If it is moving with tongue protrusion,
Yes.
it is thyroglossal cyst. Putting other
Thyroglossus.
aside, and then we
Yes.
have to talk about other details. Okay, sir.
Yes.
Okay.
It's a central swelling or it's the peripheral swelling. Is there a sinus? Okay.
Right.
Is it finger? Is it inflamed? So all these points you piece together and tell that it is probably a goiter. So probably a simple goiter or a pubertal goiter.
Right.
Okay. Anything else you want to know? Apart from this, any general questions in examination? We'll wind up after that. We had 4 good cases today. We'll do more such cases in future. You have any general queries?
Sir, what will be normally the command in the case of like short stature or tall stature? What will the command normally be?
Examine this child is looking tall for me. Can you examine and tell what is the likeliest cause? So if you may not be told that it is a hypermobile joint. This is another way of looking tall stature. This child is short. Please examine him and tell me what is the likelier cause. So can you examine the child may be having rickets. So can you examine his lower limbs? So the command may be different. It may be different from one candidate to the other candidate. Okay. So, but usually it will be easier only. Usually you can identify as soon as you recognize. These are some of the difficult cases, but mostly it will be you will have one CVS, you will have one abdomen, and you will have definitely one CNS. If you are lucky, you can have RS. If you are lucky, you can have MSK. Otherwise, they may keep your others. So even they may keep a skin case also. If you are going to be in Nepal, so they have this tuberous sclerosis case in Nepal. They bring every year after year. So you may get others in Nepal. You can get prepared for that. Any other question?
Would be
Sir,
the
in
opening
India,
Can you please repeat
which cases can we expect?
how to check?
Dr. Sheikh?
Sir, in India, which cases can we expect?
In India, see, definitely you will have a serious case. You may have a rheumatic fever, rheumatic heart disease. Then in India, you can have a rickets. Rickets is very common in our place, and wherever the centers they will bring rickets easily. Abdomen case is very easy. Then you see in this case, you have a variety of CPs in our country, so it is not a problem with the CPs. So these are some of the cases, but it depends. You don't have this artificial eye cases and all in India. If you are going to take it in Singapore, or if you are
Exactly,
going
sir.
to take it in Hong
That
Kong,
and cystic fibrosis, these and all cases
yeah,
will not be there, I guess.
yeah, you can have cystic fibrosis. Even in Chennai, they kept on cystic fibrosis. Bombay, they have cystic fibrosis. they can keep cystic fibrosis also.
This time we have it in Kolkata, sir.
Yeah. So Kolkata is a little bit of easier center. Everybody says. So you can have stop.